Hey, Tom, I just want to confirm if you could hear me.
Hey, Peter. Yes, I can.
Okay, thank you.
Good afternoon. I'm just checking in to see if all the board members are here. I see Lunge, Merman, Walsh, and now I see Holmes. And Mr. Pronovost, how are you?
Sorry, I was drinking. I'm fine, thank you. Thanks for inviting me.
Yeah, great. I'm Owen Foster. I work with Tom here at the board. Thanks for making time for us.
Perfect. Yeah, I'm excited about it.
Okay, great. Okay, seeing that everyone is here, I'll call to order the Green Mountain Care Board's hearing of March 5th. We are very fortunate today to have a guest speaker who will provide some insights and experiences on looking at hospital costs and hospital opportunity to streamline operations. What was done at the University Hospitals of Cleveland, we're very consistent with what we're trying to do here in Vermont. And so we're really appreciative of the time that Mr. Pronovost has made for us. I'll have Member Walsh introduce him in a moment. But before we turn to that, I'd like to bring up the Care Board's meeting minutes of February 21st, and I move to approve the meeting minutes.
I'll second.
All in favor, say aye.
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 Aye. And the minutes are approved. With that, I'll turn it to Member Walsh and to introduce his speaker. And thank you, Member Walsh, for organizing and planning all of this work on behalf of the board and the state.
Great. Thank you, Chair Foster. So good afternoon and welcome, everyone. It's a pleasure to see all of you here to join us in a presentation and discussion with Dr. Peter Pronovost. I see many of our usual attendees, some leadership from our hospitals, our hospital association, independent healthcare providers. Just got a note from the Office of the Healthcare Advocate, who's going to be in touch with Kristen regarding the link on the agenda. I also see some new faces, some business leaders, union members, members of the state legislature, staff from the Agency of Human Services, staff from offices of the state treasurer and auditor. It's all terrific to have you here with us. I also see some of our most engaged members of the public. And I started to look before I started reading for Walter Carpenter, a longtime healthcare advocate who attends most of our meetings. If he's not here, it's only because he's at work where he cares for the facilities and serves the people visiting one of our iconic ski mountains, Mad River Glen. For those of you who may not know, Walter is featured in the latest issue of Time magazine. I hope you take a moment to find and read the article, and we'll have the link available after today's presentation. The reason Walter is featured is the reason that brings us together today. The costs of healthcare have become unaffordable, and an unaffordable system, regardless of the industry, can never be a sustainable system. The crisis forces some patients to choose between paying for care and housing. Medical debt is a major contributor to personal and business bankruptcies. Yet the crisis of healthcare affordability also creates challenges for healthcare providers. Independent healthcare providers cannot afford to offer coverage as a benefit, and hospitals too struggle to pay for their employees' insurance. Perhaps surprising to some, healthcare workers tend to be high healthcare utilizers. Health insurance providers have raised their premiums, but not quickly enough to keep pace with rising care prices. We find ourselves in a broken system where many patients, providers, and insurance companies are buckling under the strain of keeping up with those rising prices. As healthcare is intertwined with our well-being and our system links care coverage with working, the price of healthcare for the labor force, think teachers and construction workers, also drives our education and housing crises. VPR's Lola Dufert had created an excellent report demonstrating the interconnections between healthcare. Listen to her work school reform talks dominate in Montpelier, many ask, what about healthcare? And we'll have a link to that later this afternoon. For over a decade, the rapidly rising prices of healthcare services have fueled the healthcare affordability crisis. However, it remains unclear how to tackle this issue effectively. And while many efforts have been made, none have significantly slowed the rapid rise. Many people in Vermont have long advocated for a single payer solution, such as Medicare for all. More recently, some national leaders have begun calling for Medicare prices for all. Phil Longman, the senior editor of Washington Monthly Magazine and the policy director at the Open Markets Institute, recently described this approach. Currently, however, Vermont hospitals charge 2 to 5 times what Medicare pays for healthcare. So there's a fear. There's a fear that if we reduce prices so they are closer to Medicare levels, patient care will suffer because hospitals will have to resort to cutting needed patient services. Well, that is one way to respond. However, it's not the only way. There is a choice. And rather than responding to an imposed price reduction by cutting services, some organizations facing financial pressures proactively reduce their operating expenses while preserving patient services. The choice to minimize non-clinical operating expenses while focusing on the organization's mission is not dependent on participating in any complex federal programs. That doesn't mean such an approach is without its own challenges, and that's where today's guest comes in. Peter Pronovost is the Chief Quality and Transformation Officer at University Hospitals Health System in Cleveland. That's the main affiliate of the Case Western Reserve University School of Medicine. Their health system consists of 18 hospitals, nearly 3,000 beds. Dr. Pronovost is an internationally renowned expert on healthcare safety, reliability, and outcomes. He's a prolific author with over 1,000 peer-reviewed publications, which is just astounding. When he arrived at the UH health system in 2018, the quality of care had been on the decline, error rates had risen, and the system was struggling financially. Within a few years of his arrival, quality and safety had begun to improve. However, system finances remained a considerable concern. So in 2022, Dr. Pronovost led the implementation of UH's Medicare Break-Even program. He'll provide the details, but the main objective was to address the health system's financial challenges by redesigning care so the system would break even financially at Medicare reimbursement levels. And to do this without cutting patient services or witnessing any deterioration in safety or quality. The program is ongoing. Operating expenses have been reduced by over $400 million. There have been no service line reductions. In fact, some have grown. The Medicare Break-Even program's success has been detailed in Becker's Hospital Review, which is a prominent news source within the healthcare industry. I invited Peter to share his story, both the successes and challenges, and to discuss his key takeaways from this work. He graciously agreed. So, Peter, thank you for being with us. I'll let you take it from there.
Great. Thank you, Tom. And thanks all of you for having me. And I'm going to share my slides. So let me just get the slides. Perfect. Okay, great. So thank you all again for agreeing to host me. Let me just put a little context in this story because I'm going to share our journey and fully transparently with our warts and mistakes. And there were plenty, but more importantly, what we learned and what we accomplished. But I hope this audience could see that we're more alike than we are different. Despite my longtime love of Vermont, having growing up in Connecticut and skiing many times in your mountains and hiking in your beautiful green hills, we're a large academic health system. We have 2,000 residents. We have 3,300 clinical trials. We have about a $250 million research portfolio. That's just our health system, not the whole case. We have 3 critical access hospitals. We have 3 Medicare dependent hospitals and a big academic flagship. And we were struggling. And let me share my thesis of leading this work, and it kind of culminated a whole bunch of the things that I've learned over my last 25 or 30-year career, is that the biggest problem healthcare, maybe the world faces, is our inability to solve complex problems collaboratively. And the biggest reason for that is a lack of love. Now that may sound jarring to some, perhaps it's intentionally, but let me be very clear what I mean. Love is a mindset that is the energy that is within and connects us all. It uplifts and elevates us. It says that we are all innately worthy. I don't need a degree after my name or an MD or a fancy VP title. And it believes in the goodness and the power of people, that when I connect good, well-intentioned people to solve problems, we innovate better, faster, cheaper, and we learn better, and innovation flourishes. The opposite of love is what we see, I think, in healthcare today, and what Tom described a little bit. It's separation, or if an economist, you can say scarcity rather than abundance. Love's an abundance mindset, that we look down on people. We see others as competitors or trying to get at us in this zero-sum game of we're fighting for what we want. We say, if you're not like me, or you don't have a MD after your name or a vice president title, then your voice doesn't count. You don't understand my problems. To the such that many people begin to question their self-worth. We demean, we demoralize, and most importantly, we destroy the ability to add value. That mindset hasn't worked in healthcare for 30 years. And as Tom said, healthcare costs aren't anything new. It's just we haven't really found a way to solve them because we've been at this scarcity mindset of fighting. And I want to share with you what this might look like if we changed our mindset. We call this concept living and leading with love. It's our moral philosophy that guides all of this work. And why did we need to begin to embark on this, and what was the driving force? Well, what I would share with you is the math wasn't working. And we looked at our hospital, and this was in 21. The cost per discharge was around $21,400. The revenue per discharge was $17,600. It was a little bit less, that delta, for surgical patients, but we still lost a fair bit of money, maybe about $500 to $600. For medical patients, we lost a whole lot more money. We, like you, are in a community that has a overall population decline. The only population group that is growing is our Medicare patients. Our younger and commercial insured are decreasing. That may not be what you have in Burlington. And is like you, I suspect, the only payers we make money on is the commercial payments, right? And this is true of every health system in America. And the logic, and again, my mindset of a health system executive is, well, we need that to offset the underpayment from our government payers. So we have to, of course, charge the commercial value. But what we haven't said is the fundamental problem is our cost structure. And this isn't sustainable. And if Medicare is going to be our main payer, and with the new administration, that looks like Medicare in some form is going to grow, we are going to need to get our cost structure down so that we're profitable on Medicare level payments. And that was a frightening proposition because we are in the scarcity mindset of, and I'm sure, well, those of you who are on the health system side know it. I run essentially the health delivery system, everything except the directly employed doctors and nurses to drive value. And I run about an 800,000 member ACO. Our overall hospital revenue is about $6.2 million a year. And the picture was gloomy. In 2002, we lost 320 million on operating income. We have some investment income, and we received a bunch of government subsidies, but still lost a ton of money. In 23, some of that, got down to 256, 24, 156, 25, 62, forecasted for us. For our health system, I suspect, like you, we need about $400 million a year of EBITDA to keep up with our depreciation and program building and our research programs. Healthcare, as you know, is a very capital intensive business. And this is not a transformation overnight, but what I want to share with you is how we made this transformation and what some of the impact that we have. And I'm going to spend a few minutes on the cultural piece because so often it's viewed as the soft stuff. And I will share with you, it is the essential stuff. If we don't change this mindset, that it's not going to transform. Because our board, our executives, our whole health system believe that our purpose was to have a full hospital or full health system. That, like, undoubtedly, all of our metrics were geared towards that. And you could say, well, maybe they weren't. No, we serve our community. But what do we report at board meetings? What do we report at executive meetings? Our P&L, number of discharges, not defects in those discharges. So what do I mean by that? Well, when we started this journey, I sat with our board. It was actually one of my earlier meetings. And I put 2 chairs in the front of the room and said to the board, the chair on the right is how you're currently looking at our performance. And that's largely through the lens of hospital administration. On the chair on the right, I want you to look through the lens of someone who's paying for healthcare, because most of you are employers or business people, or you're paying taxes. You are paying for it. And I want to share with you the story of Helen. Helen is a 64-year-old woman who was admitted 15 times with heart failure in our last year in our system and had 14 emergency department visits. And every time Helen showed up, the part worked perfectly. Helen got great transactional reactive care. She showed up in the ED, they did their narrow job. Got admitted, those hospitalists or the cardiology consult did their job, and she got sent out, and she came back. Helen cost her employer $1.5 million. Helen has a copay and coinsurance like most of us do. 20% of $1.4 million is a lot of money. Helen is in personal bankruptcy. And all of it was a defect. You see, Helen didn't need to keep being readmitted. She wasn't on guideline recommended therapy. You may or may not be aware, across the country, 15% of chronic disease patients are. But more importantly, we totally missed that what was driving Helen's readmissions, like is the majority of people, was a behavioral health problem, anxiety. We didn't diagnose it. And because of her anxiety, she would often miss her appointments. Helen also had a challenge with respite care or getting to her appointments. You see, her daughter had died of a narcotic overdose, like over 100,000 Americans, and far too many people in my state. And she didn't have respite care to watch her granddaughter who's disabled, and she was the one who felt comfortable she could care for them because we don't pay for respite care. in our insurance system. So she would skip appointments, and until she would get anxious about that and the breathing would get short, and she showed up in the ED, and we would give her transactional care. I'll summarize what we built in the story of a different patient, Rose. It is what I would call relational and proactive care. Rose has heart failure and is 64 years old and stunningly similar to Helen, but she's never been admitted because Rose gets her care at an advanced primary care practice. She, like all of our patients, get referred to a pharmacist who manages her chronic disease to make sure she is on guideline recommended therapy. We run it out of a 340B pharmacy so that if we could get some coverage for the cost and to pay for some of the physician's time. She gets social work to help diagnose and treat her anxiety and has a teleconsult with a physician when needed, but it's really just to confirm the diagnosis and the care plan. Helen cost Medicare $800. What's the difference? The first case is riddled with defects in value that are largely invisible to us, to all of us. We're swimming in them despite measuring 250 things, or 2,000, I'm sorry, 500 things with CMS. We're not measuring the right things. We're not measuring these defects in value. Rose's care was largely defect-free. There's still a lot of waste. To put this into context, 4 years ago, our per member per year spend for our 42,000 Medicare members in MSSP was $12,800. Last year, it was $9,600, and that's not accounting for the about 8% of inflation per year over those 4 years. So without inflation, we took 33% out of Medicare spend with no change in our incentive system. We're level B on MSSP. We just recently went to downside because our board is very conservative and didn't want to get downside risk. So the proof points are really, really palpable. Two other proof points. I told you we were mediocre at best quality care. A year and a half ago, we won the American Hospital Association's Quest for Quality Award, the top quality hospital in America. Their review is quite rigorous. They have about 6 people spend 4 days interviewing staff, looking at our data. When they left, the only comment they said, Peter, okay, we can't tell you that you won because it's supposed to not happen yet, but we haven't seen anything like this culture change in healthcare. My only question is, how do you spread this? You said it's nothing magical. There's no external things. It comes from within. It comes from love. Last year, we won the International Hospital Association Award for the top leadership and management system in the world. And I say that hopeful and humbled. Hopeful because we have proof points, it works. This isn't like a joke. Humbled is that when I say we took out that 30% of Medicare waste, full transparency, there's at least another 30% because the defects are still around in so many things. And so I think healthcare could be so much better, and I want to push on this approach. So how do we operationalize love, and what the heck does this mean? Well, all we simply did was build upon and integrate 3 well-developed philosophies or management principles that have been around for thousands of years that nobody's put together in an organizational context. The first is believing. And what that simply means, there's compelling data that when every employee connects what they do to the purpose of the organization, we excel performance about 4x. In healthcare, it should be easy. We save lives, we reduce suffering. The reality is most healthcare staff don't feel connected to purpose. They feel a lack of love. They feel separated. They feel their voice isn't heard. So our belief is really key. Every leader, every manager, every staff, this is leadership behaviors, says that we will treat everyone with respect unequivocally. We will create every employee space to unleash their full potential. And we will make sure that we share stories that link people back to purpose. Second management principle is, where does innovation arrive from? Innovation arrives when you create a structure and a culture that allows the free flow of ideas and promising practices. We happen to call it a fractal. We'll get to that in a minute. But essentially is, do you have a mechanism for ideas to meet, mate, and mature? And within our organizations, especially someone like the size of UVM or within your great state, for almost every problem we're solving, somebody has hit it out of the park, but we don't have the networking, that structure to allow the free flow of ideas, or more often, we don't have a culture that encourages to speak up. We have a culture of scarcity that says your ideas only count if you have a degree after your name, or whatever that attribute is, or you don't stutter like I do all the time. So what does belonging mean? That we will say, we will form trust by doing things with rather than to people. You'll hear more about that. We ensure we have the structure for solving problems and connecting every level from board to bedside. And we will create empowered spaces where all voices are heard and honored. Third, and maybe the most important, but you can't do it if you don't do the first two, is building discipline management and shared accountability systems. There's overwhelming data, much of it from Nick Bloom, the Harvard economist and management guru, that says good management matters and good management is almost entirely absent in healthcare, right? And my health system cringes when I say it's not my evidence. You can go read it up. There's plenty of it published in the National Bureau of Economic Research. It's around the world. And I mean basic things like what % of projects have a goal? What % of projects have a clear measures or outcomes? What % of projects do you feed data back to the team trying to improve it? Do you make it easy through tools, technology, training to do it? And is there any semblance of shared accountability where if you don't hit your mark, someone's looking at that? We use the outcome key results framework on focusing on measures that matter. And it's really simple. Literally every leader in the organization says, if you cannot show a system level run chart for something that matters, you do not have a management system. We'll work with you to make one, but don't waste my time telling me about what you're doing is planning meetings, because we lived in healthcare thinking inputs are outputs. And we need to do those. They're not moving the needle. And secondly, if you do not transparently show performance by hospital, by clinic, by unit, by physician or nurse, you do not have an accountability system. Now, it's not a finger wagging, blaming people accountability. It's shared. We take our love concept very seriously. Shared accountability means as a leader, we could only hold a lower level leader accountable if we first set them up to be successful. That is, we hold ourselves accountable first, that leader knows the goals, roles, expectations. They have the resources and the data systems to do this, and we help build that fractal structure for ideas to flow. That's my job as a higher level leader to do, is to build that management system that is executed then by our market, our local leaders. And then if they're not performing, to nudge them and support them, and those who are performing to celebrate and learn from them. The key way we instantiate this is a weekly transformation call that we call it our illuminators. That term I borrowed from David Brooks' last book called How to Know a Person, where we describe illuminators as people who connect, uplift, and improve others in the organization. And those things are key because these people who build trust, who are boundary spanners and link different silos in an organization, are the key. So every Tuesday morning at 8 o'clock, there's an illuminators meeting. It's open to any of our leaders. We typically have around 250, sometimes 300 people on. We often have outside guests. We don't share any PHI. We also have Illuminators Awards, where if you see someone who is acting like an illuminator, who's doing these things, we recognize them once a month, and we have a little pin. The beauty of it, it's not a zero-sum game. There's no judgment. If you think someone's an illuminator, there's an illuminator, and our goal is to have all 33,000 of our employees to be illuminators. So let me just go through a little bit about believe, belong, and build. We said, okay, how are we going to help make sure everybody believes in our purpose? So we went through literally every role at every site, or we had set up a structure to do this, and asked various teams, what do I need to stop believing and start believing for me to see that I believe I'm connected to this purpose? And I just put one, we have literally hundreds. They were all the same message, stunningly the same message. They were all the message of separation or lack of love. Here's what our transport teams say. I'm going to stop believing that my voice is not heard and will not be heard. And I'm going to start believing that if I speak up, change happens. Now, if this may sound trivial, but this was literally done every role at every one of our hospitals, in every one of our ambulatory clinics. It's not surprising that the engagement is 4x higher, because now I have 33,000 people who are energized and empowered to solve problems. And you have to follow it through with what their roles are. We'll get to that in a second, but this has been transformative. Second was changing our managers' mindset about belonging and how do we have innovation flourish. You see, too often healthcare leaders treat people like these fleas in a jar. And so the story that I'll share with you, if you put fleas in a jar and you drop them in there, they will immediately jump out. They don't like being constrained like our workers do. If you put a lid on the jar, they will jump and bump their head for typically 2 or 3 times. But then they've learned not to aim to get out of the jar, and they stop jumping out of it. They stop jumping as high. But when you take that lid off, they will not jump out again. They've been conditioned. We, my friends, I think, have conditioned our healthcare workers to be told to follow this rule or follow that checklist and not solve problems. And so too many of them have decided not to try. But it doesn't need to be that way. Because if you see people as beautiful and brilliant, and your job as a leader is not to command or control, but to unleash and inspire that brilliance in people, you could transform like this picture has done. So the picture on, if you're looking at the slide on your left, is Death Valley, which, as you know, is one of the driest, most desolate places in the world. In 2004, Death Valley got a fluke rainstorm of about, I don't know, an inch or two. And a month later, same spot was a bed of these beautiful wildflowers, just like majestic. And what's the difference between the two slides? Well, the seeds were in the ground. Those seeds of brilliance, of potential, were always there. They simply needed to be watered. So I mentioned the way we belong and innovate is this concept of a fractal. And so let me just explain it, because it's not a nerdy math term. Fractals are ubiquitous in nature. Our capillary alveoli, glomeruli are fractal. Ferns, broccoli, snowflakes, riverbeds, mountaintops are all fractals. Fractals are identical size, identical shape, but varying size structure. And fractals operate by simple mathematical rules, and they evolved in nature because if every time an organism wanted to grow, if it had to write new genetic code, it would be highly efficient. So they just repeat their building blocks in different shapes. Brilliant idea from nature. Our simple mathematical rule for innovation is every higher level of the organization needs to create a table where every lower level has a voice. And that is probably the most trust-building management structure the world has ever seen. Because we know that change progresses at the speed of trust. And trust grows when we do things with rather than to people. So concretely, what does a fractal do? Well, it allows us to co-create goals because people are at the table. It allows us to learn horizontally from each other, one unit, one clinic from another, one department from another. It allows us to have accountability by vertical connection. So I can make sure from board to bedside, if we have a darn goal, every level of our organization, it's driving it. Concretely, let me see how does this play out to do this. We messaged to all of our organization that they needed to be bluebirds and not robins. So the story behind that. In 1940s, London was full of two melodious songbirds, the red robins and the blue boobies. And they thrived in downtown London because they used to peck through the tops of the milk containers that were left on people's stoops. They were cardboard and steepled, and they would suck the fat out, and they were really chubby, well-fed birds. But then the companies changed from cardboard and steeple to aluminum and flat. And both birds are equally smart. And a few of both birds learned the new pecking technique. But the robins are extinct today, and the bluebirds are thriving. And the robins are extinct because they're solitary birds. They have their corner, their stoop, their hospital, their health system, and that innovation, that wisdom never was shared. The bluebirds are flocking birds. They fly strong and proud together, and they quickly learned this new technique. My friends, we are like robins, and I believe deeply that not-for-profit healthcare in this country is at risk of going extinct, and it can't, because it serves the community, our community, and it always will serve our communities. I don't believe PE funded or the Amazons are ever going to be there to care for people in the middle of the night, or to deliver babies, or to care for traumas. It is going to be places like the health systems in your state, but we need to learn differently. So what concretely now did we do for building our management systems? So we had subdomains to say, get paid fairly. What did that mean concretely? Well, we converted 3 of our hospital to Medicare dependency program hospitals. You probably know those very well. In Vermont, we need an average daily census under 100. We get paid a higher rate. And the hospitals deserved it. We weren't doing that. It helps them. We weren't coding well. We had a lot of opportunity for coding. We were horrible, particularly at surgical coding, especially in our academic health system. And we were even more horrible at billing for our supplies, where about 1,000, 1,200 supplies weren't even in our Oracle system. So our nurses had to go try to look up something which was ridiculously burdensome. They didn't do it most of the time. And we were invisible to all those defects. Second, we had to improve access. And I won't go to the details about them, but we had our physicians largely locked out their panels. And it was blind. There was no transparency. There was productivity was in around the 60% wise, though many people were in the 40%. Would put slots in to make sure people had access to our community. And the reason is because lack of access is harm. And our goal is zero harm. And delayed in access is suffering. So people waiting months or weeks was not acceptable. That was a huge culture change, because our docs may even said, well, I like caring for this type of patient. Like, that's great. If we had 3 times more of those or 5 times more, we can do that, but we don't. So you can see those patients, but you're also going to see other types of patients. We can't afford to pay people salaries and not have them seeing patients. Ton of work on reducing cost per discharge and per visit, and maximizing ACO performance. And so I want to spend a little bit about every one of these. Every one of these used the Believe, Belong, Build framework. From the management system, they all had to have an outcome they were driving and a key result they were improving. And when we asked people to do that, it was very simple. Your charge is to identify and eliminate defects in value and harm. And those defects are in 4 categories. They are zero harm from diagnostic or therapeutic errors. They are zero suffering from waiting. There are zero waste and they are zero inequities, meaning any subpopulation that has a worse outcome than our average population, or people aren't getting what they should. We also grouped those defects in value into 3 domains to make it really crystal clear that this isn't a hospital thing, it's not an ambulatory, it's everything. And those defects are defects in helping people stay well. So preventative care, cancer screenings, immunizations, annual wellness visits. Second is defects in helping people get well, and that is for any chronic disease, we made measures of defects, not just like diabetes A1C, but that I had all of the following. Am I diagnosed accurately? Because we know 50% of people with chronic disease aren't diagnosed. Am I on guideline recommended therapy? I also mentioned 15% are on guideline recommended therapy. Have I been screened for behavioral health and referred? And the same for social needs. It's about 60% of people with chronic disease have behavioral health issues. If you do, your costs are 2.5 to 3 times more. And we screen or refer about 2% of people. Like same with social needs, ridiculous. And then finally, have I avoided needless visits? And then finally, defects in helping people get better. So on the hospital side, is the site of service optimal? So and home is the optimal for all of these. Is the service that I'm needing appropriate? 60% of spine surgeries aren't needed if you do follow appropriateness criteria. So we rigorously put those in. Have we avoided complications? Am I in the lowest cost setting possible? So you can see a lot of principles that guided this work as we roll these work out. Specifically for the Medicare break even, we put this charge in. Our CFO that really liked it, our CEO did. And when we were losing money in 2022, our first move was to do a RIF. And, RIFs are gut wrenching and hard. We had a lot of waste. We needed to do them. I think the first round, we maybe got about 150 positions out. Most were unfilled positions, and it didn't really move the needle on this work. Before we did the next round of work, though, we used this outcomes and key results. And if I would encourage the health systems to try this. Every org unit in our organization, so essentially we started at a higher level of all the reports to the CEO and then cascaded it down, is make a functional org chart. Because we got so bloated in healthcare by adding positions and FTEs, and many of them aren't clear exactly what they do or how they add value, or there's overlapping and there's turf wars, and we spend more time who's reporting to who and accumulating reports than we do getting rid of waste and defects. And again, this wasn't without controversy, and we needed to support teams on how to do this a fair bit, because this functional org chart idea was often not common. So I'll give you, in our ACO, what are the functions that we do? Well, we have to optimize our network to make sure the high value docs are in it. We optimize our plan performance for every contract, and that means our RAF scores, our quality measures, our per member per year spend. Third is we optimize our care management programs, and all of those have examples. Once you do a functional org chart, you then say, okay, who's doing this work here? Forget the name, forget the reporting. Who's doing the work, and do we need all these people, or do we need new people to move them around? And it is eye-openings. Next round of RIFs was about 400 or 380 people. And surprisingly, though, much less pain than the first one, because making RIFs when you don't change the function of the work just adds risk to your organization, because people are still thinking they're spending their time doing what they were in the past, as opposed to reorganizing the work. These other risks, we put in a system that said, red, yellow, green, if a risk is going to put us at material risk, let's discuss it, and we won't cross the stupid line. But what happened in almost all of those, people would present this as a material risk. We would sit down and say, okay, how are you organized? What are the functions you're doing? How many people you need to do this? And there are ways to make that reduction without crossing the red line, but we had to have the mindset of collaboration and breaking silos and not these are my FTEs. And these RIFs, by the way, including many at our management, because we got really, really bloated. In many ways, I felt like we were a bank where we had a whole lot of directors and vice presidents, many who didn't have a span of control enough to allow for that. And so we could have VPs with 1 or 2 people in, or directors. And again, we're a big organization. These things evolve over time, but that we pretty rigorously, and then everybody got outcomes and key results. So we took the pain of getting these cuts in, and then we inspired people to say, we want to be the highest value academic health system in America. And we're going to do that by making all these defects in value visible, and then you design them out. We're not going to micromanage. You know what it is. We'll set up the management and accountability system, but we will be looking at what you're improving on. We will support you. We'll give you the tools, and we're going to drive performance. So what I want to share with you is a couple of examples of proof points. And these aren't meant to be exhaustive, and I don't want to go into the details. All the intention is to say, I told you is our mantra was, if you don't have a graph that's measuring something meaningful that has a slope that's greater than or less than 0, you do not have a management system. It is that simple. We had almost 0 in 2019, that if you were to go to any executive and say, could you, like right now, what are you managing to? What do you mean, Peter? What are you managing to? Just could you go pull up a run chart right now of saying, what goals are you doing? But and I have we use a Microsoft project called Viva Goals that we put all of our OKRs in Viva Goals. It automatically links from Power BI to pull up reports. It's highly efficient way of scaling OKRs, because in this portfolio, I mean, I literally have thousands of OKRs, but they group up in aggregate like a fractal. But it's a way we look at variation in these. So denials, length of stay. So like you, we're about 3,000 beds. Our academic health system for years said, Peter, we're different. We have sick people. We can't get our length of stay down. And we said, okay, I don't want excuses. I want to know, what are you managing to? Maybe you're right, but right now you don't have a management system to do this. And we drove performance in incredible ways. In our surgical patients, I don't know if there's any health system leaders truly blown away. We put in ERAS, Enhanced Recovery After Surgery, in all of our 18 hospitals for 16 surgical service lines. Our system surgical length of stay is 0.84, and in our academic hospital, it's 0.94, right? We do transplants and thoracic aortic aneurysms, all the super high-end stuff. And it was the same learning I did around bloodstream infections in the country. Before we set a goal of 0, every hospital was complacent being average. But that average was people doing what they're supposed to about 30% of the time. When we changed the mindset of going to 0 and ensured people did the processes, did the checklist 100% of the time, we virtually eliminated those infections. And so I think our length of stay and cost benchmarks we could blow them away. We implemented a mobility program. We started earlier on, before COVID, it crashed, but these are data from our whole system. We're now up to 75% of our patients get mobilized 3 times a day. And you could see transparently reporting what those bars in the bottom are hospitals that are doing this. We have about a 70%, 72% enrollment in ERAS. Still not good enough, but going up every year. And here I mentioned our surgical length of stay, just like breathtaking. Sentinel events across the system, plummeting, 70%. Medication safety, we were like Einstein's definition of insanity, doing the same thing for years until we did one simple thing. We started reporting performance at every nursing unit level, and every nurse got reviewed their performance. And lo and behold, near perfection. Same thing with Omnicell overrides. And again, I can show you some of these things, but the key is this management and shared accountability system. Beautiful thing we reduced 2,600 policies over the last, I don't know, 7 or 8 years in our system. And I'll share with you this beautiful demonstration because it's waste. I was meeting with, about 250 of our nurse leaders who we have a system-wide policy committee where they, for years, are supposed to looking at what policies could we get rid of. And there wasn't previously a single one that they reduced. And so I met with them and said, like, how come you don't do this? Like, well, I don't think we could really do that. So like we talk about things, but who are we to be empowered? And so I said, okay, let's just set up an hour brainstorm session. You are empowered, and I want you to come up with 2 things. List policies where the burden exceeds the benefits. And then where are you doing tasks that technology could solve for you? And they came up with, in 30 minutes, about 130 policies that were mostly frequency of vital signs that weren't CMS driving us. They were our own self-imposed punishment. And again, it's like, oh, well, we can't change that. We said, no, you could change it. And our chief nurse executive, strongly supportive and working with me on this. Those 120 policies were embedded in around 1,200 order sets that we had to go change, but it freed up about 25% of our nurses' time. Now, how did that get manifest? Well, in 2021, we spent around $400,000 in premium labor that, through agencies. In 2022, we spent $10 million. Think about that. We got no more revenue, but a $10 million hit. We're now down to about 4 million, maybe 3.5 million. We're trying to get that back down to 1 million. But it's these kinds of things that were waste that we self-imposed that we did this. Our annual Medicare wellness visits went from 14% to 80%. The national average is around 13%. And there's real benefits that happen to this. Cancer screenings in the country plummeted during COVID, largely because of the annual wellness. These continue to go up. And if you say full transparency, I should update these slides to 2024. My apologies. I just don't have time, but I assured you every one of these curves are going up. Beautiful for our managing of chronic diseases, we created these things called systems of excellence, where in our old model, specialists managed 90% of diseases, and we largely believed you were good by correlated with how long you had to wait to get in. So our really, really good neurologist or endocrinologist would have 6 months of wait, and we almost prided ourselves on that. Oh, they must be super good. They're in demand. And so we met with our specialist and said, okay, let's do the math. We'll just take diabetes, for example. We have 62,000 people with diabetes in our ACO. We have 3, maybe 4 endocrinologists who do diabetes. If all you do is diabetes, which you can't do, you could maybe see 1,000, 1,500 patients a year. The math doesn't work. So we're going to work with you to design a health system where you care for the sickest 10% of patients, not 90%, and 90% are cared for in primary care. And they were energized because they're like, Peter, the only reason I care for them is I got to cover my RVUs, but I'm wasting my time. Most of these patients they need a protocol. So we pulled endocrinologists, primary care, diabetic educators, nurse practitioners, pharmacy, and said, create a checklist. When a patient with diabetes shows up in primary care, what should they do? And specialists, what you need to do is we'll build a tele system or in person to do a quick consult that confirms the diagnosis and treatment plan, and you only long-term management that 10%. And now we've built such trust that the reason we're getting these results is any chronic disease patient is now an automatic referral to pharmacy. At first, we didn't have pharmacists in our primary care and the docs didn't trust them, but we intentionally built trust because we did it with them rather than to them. I mentioned about how do we survive in getting this cost down. Well, when we looked, we saw that 70% of our general medical admissions didn't need to be in the hospital. They needed care. they didn't need to get care in the hospital. Same thing with emergency department visits, 60 or 70%. Now, I mentioned we lose around 3,000, 3,500 every one of those medical admissions. But more importantly, they're also blocking access to cancer and procedures that need care, but we're often not able to get in there. So we aggressively went to avoid, as a strategy, keeping people healthy at home rather than healing in the hospital. And we set up a variety of mechanisms to keep people out of the hospital. And that was much like a med safety of preventing the error, keep it from getting the patient and minimizing harm. We set up with our paramedics a paramedicine program where they go out and visit patients. They work on protocols. They keep patients from being referred. If they need a televisit, they can connect them to this hospital at home virtual clinic to get without having them to go anywhere else. If we need to send home care, we've broken the silos. All these people are sitting in the same coordinated center we call it the web of well-being. If they show up in the ED, we have about 4 different programs that can get them into a tele primary care visit or a real primary care visit within 48 hours. We built a mechanism and trust with our primary care to say, you're just going to overbook. If you're full, you got to take one of these patients because we're avoiding admission, and you have a no-show rate. We have 48-hour specialty referral through this. We have direct connection to Healthy at Home, direct connection to SNF, just as an example of navigating this. And we also refer direct from admitted patients to shorten their length of stay to this program. Now, if you think this work, okay, is just cost reduction, our patients may have it. We measure Net Promoter Score, as most businesses do. Net Promoter Score, if those of you don't know, it's essentially measures willingness to recommend on an 11-point scale, where it takes the promoters, which are 9 and 10, minus the detractors, which are 1 through 6, and it eliminates the 7 and 8s because they're just kind of neutral. This isn't just the Press Ganey willingness to recommend, because Press Ganey uses a 5-point scale. Press Ganey allows you to add questions. So we added the 11-point Likert scale, just so you know, so it's legitimate. Just to give you an example of where this compares to other organizations, great organizations are largely around 30. Negative is obviously doesn't do well. And top performers are like anything above 60. So Ford is 28. Our health system is performing better than Amazon, Southwest Airlines, Netflix, Apple, Google. And again, this scores have been going up just like every other thing year over year. When we started we added this question about 4 years ago, we were down around 57 every quarter. And just so in case you think this is bogus, the response rate on this is somewhere around 350,000 people. We also rocked it in our shared savings so that we now have around $50 million a year of shared savings. Just so you know, our EBITDA is around $120 million last year, which means our shared savings was around 40% of our EBITDA on a ACO budget that cost the health system $1 million, because most of the infrastructure are paid by care management fees. My budget's around 19 million. I get around 18 in care management fees, and then we get incentives for quality and reducing spend. Here's just what our annual year-over-year improvement is: driving zero harm, year-over-year improvement, and now it's around 40% of our EBITDA. Here, I mentioned that the cost takeout. This doesn't include the RIFs and doesn't include a lot of the things we did, but one of the programs that I also run is reduction in clinical variation. So reduction in the length of stay is included in here, in lab use, in imaging, in blood use, because we're not paid extra for those in the hospital. They add to length of stay. Some of it we moved to ambulatory, but most were just wasted. We didn't need that. We generally return around 45 or 50 million a year just from clinical optimization. And what I will share with you is my quality budget or my like safety, I don't budget dollars. My ACO, I'm budgeted to shared savings. Like this year, I budgeted 55 million. I budget for length of stay takeouts, and I budget for high reliability medicine, somewhere around 56 or 50 or 55 million a year, and we have to hit that. I'll add with you one really innovative thing that we've done is we were curious to say, why has innovation in drugs and devices been so great? And innovation in health delivery has been pathetic. And it has been pathetic when we have negative labor productivity despite spending trillions of dollars on information technology. There's literally no national signal that our conversion to EMR has made costs go down, quality go up. The only things it has bought is burnout and more billing. Doesn't say we don't need it, but it hasn't delivered performance. And in any way, so we got of what I'm calling venture philanthropy from a local organization. I would encourage the health systems in Vermont to try to do this. What we said to them is, you give us $10 million, $5 million a year, and I will accelerate these efforts that we're doing such that over 5 years, I will deliver 156 million in cumulative return of value. I said, we have negative margins. I can't invest I don't have the capital, but the capital produces a return. So we just doubled that investment at 5 months of this program being live. I was on a run rate to deliver 23 million in value. We delivered 38 million in value. And the venture fund, they're a philanthropic fund, they're a for-profit company that has a foundation. Like, okay, Peter, this is a no-brainer. Think big. Tell me what you want. I'm willing to deploy $10 million a year and keep this going, as you need it. So we're just finalizing our next advance on that gift to run even more and more projects. But it just shows this idea of when you live and lead with love, everything is different, because we get out of the mindset of fighting with the insurers. We have a really large insurer in Ohio, Medical Mutual, and we spent decades arguing over unit price that we did nothing. We said, okay, can we just get paid fairly? Because this is a zero-sum game. We've tried this. It doesn't work. You beat on us. We beat on them. We threaten we're going to term you. And that's ridiculous. It's not going to be good for the public. It's not good for any one of us. And it's just horrible leadership. It's not going to solve the problem. The pie could be expanded if we drive value through Medicare Advantage or other service lines. And could we work together to deploy these programs? So now we have several insurers supporting our efforts to drive value because they see this. So my closing question for you is, and I will have time for comments, is how is what you're doing working for you, whether if you're a health system, whether you're the payer in the state, whether you're an insurer, whether you're a consumer, right? Because it's not working so well if you look at the empiric data. Maybe it's working well if you're wealthy and you're a board member and you can get access and you can get in when you need, you get to specialists and you have money to pay the copays. Outside of that, not working so well. And so my question is, if not this, then what? And if not now, then when? Because I think it's only going to get worse with the federal changes, the need for us to be more efficient. And if not who, if not you, then who? Because you have all the parties that you need to do this kind of thing in this room, in your community right now. This doesn't need a new federal payment policy. I shared with you, none of this changed. We were in Medicare MSSP level B the whole time. We now are now at downside at level F. But no payment changed. What changed was we decided to live and lead with love. So I thank you, and I'm happy to take questions or comments if we have time, Tom.
Peter, yes, we do, Peter. Thank you very much. I'm going to turn it back to Chair Foster.
Yeah, thank you. That was, I have so many thoughts and so many notes. So much to digest in that. I really appreciate it. I'm going to start with our staff and ask if our staff has any questions for Dr. Pronovost.
Hi, I'm Elena Barabee. I former director of health systems finance and helping board part-time. I had a question. Again, it was a lot of information. I really appreciate all the tangible metrics you shared and kind of tying the culture to the specific goal setting and changes. You know, and I think for us, one thing we're really interested in is making sure we're looking at the right measures. And it sounds like there's a lot there, and a lot of it is kind of this developed in a shared sense. But, you know, I think it would be great if you could help us understand kind of what makes a good measure and how do you prioritize amongst so many different kinds of measures, and making sure you're getting the biggest bang for your buck when there's so many places to look. Where would you start?
Yeah, so good, really good question. And I have been working to push CMS to use this framework of defects in value as a measure. And so what I mentioned, we started with our measures in really 3 big domains. In helping people stay well, so the preventative. So do you have an annual wellness visit, right? I don't know what your rates are in your health, in your state or your health system, but especially for Medicare patients, it is one of the most important things to drive wellness and, you know, make sure you drive it. And then cancer screenings, immunizations, healthy behaviors. I wish I had a way to measure that. I mean, I know you're probably more technology advanced. There's apps and tools you can do that, but we don't measure that right now. Second domain is the chronic disease measures. And I'm happy to share what we did. So literally for 6 chronic diseases, and we can call behavioral health a chronic disease. So 7, we have measures of, are you diagnosed? Because half of the people aren't diagnosed. Are you on guideline recommended therapy? And some of this takes some collaboration because, you know, for like the diabetes measures, different societies have different measures, you know, so the heart failure, the cardiologist and the endocrinologist, CKD don't all collaborate, but we just say common sense, folks. Let's just say this is how we're going to define them. Are you screening for behavior, or are your physiology controlled, or your symptoms, you know, A1C, hypertension, lipids? Have you screened for behavioral health and referred? And then the avoided hospitalizations. And then the hospital side, what I found is that because there's so much goes into it, is the cost per discharge and margin per discharge. And because you got to, you know, and then with the goal of being profitable on Medicare, surprisingly, we didn't really look at it this way. And, you know, and you know, part of the reason is, and because I'm, you know, wear different hats. I'm a doc, but I'm also at the executive table and at the policy table. You know, what would happen is our executives, our CFO, our CEO would say, we need to take out 500 million, right? Something. But if you're a doc or a nurse in the bedside, that's like monopoly money. Like, I have no idea what the heck that means to me, right? So you're not engaged in solving the problem. If, again, our Living and Leading with Love say every employee has a role, what I said, okay, if like you can manage that yourself, that's not what we're messaging. Well, like, for example, we went to all of our surgical teams and said, you know, surgery for the most hospitals is how they make money. We lose $600 per case. That's unconscionable and not needed. Let's figure out how we can do that. So that's where we said, okay, there's some revenue side, we're not billing. There's a whole lot of waste. Like, I'll give you an example. We were opening up, you know, probably, well, we spend around in our system $370 million in surgical supplies. About 25% of that cost, we opened up things in the operating room because the surgeon's card said that they should be opened up when they start the case. Those cards, every surgeon had their own card for every case and at every hospital. So what we said was, okay, get together. There will be one card per operation. And, you know, at best, if you have a reason for doing this, okay, we want to hear about it, but there has to be justification, and make it so you only open up the things when you ask for it. So our mantra was ask before open. Sounds really stupid, right? But it takes a whole lot of coordination. We got a whole lot of savings for disposable items or physician preference items. I think part of the savings was Now I think we're up to maybe 50 million this year in surgical supplies because we had, people wanted to use their stapler versus not. We are part of this premier program that we get purchasing prices. And again, our focus on safety, but in the past it was the Wild West. People did what they want because they wanted to. I wanted to try something, or I want to bring this vendor in. It was led by the surgeons, though. We just coordinated and said we're not going to do that. If this is the one we get a better price on, you could only use it if you have a demonstrated safety, legitimate reason not to do it. But please note, the things we're recommending, there's over 250 hospitals in this program, so it's clearly good enough for them. So you better have some compelling reason that we're different, right? And we never had that rigor. And a lot of it was, well, it's a safety risk for me, and most of it was, it's new for me. I need to get some training. And so we said, okay, then we'll bring the reps in and train you. Like, we'll do the training, but we're not going to give on the price. We're in the past that comfort. And we got to the point where we had a surgeon who didn't want to use a new stapler. These all have thresholds. And if the use that this surgeon was using would have essentially cost us $12 million, and said with her, we can't afford that. And like, there's an irresponsible use of resources in our community. So tomorrow it will no longer be available. You choose of how you want to use it. We have told you for now 4 months to get training, and lo and behold, not a peep when the change was made, not a safety risk, just save the resources. So like, I think it's got to be a value measure and get out of this mindset that it's just safety and quality.
Thank you.
And I'm happy to share like the metrics for those, because it would be really cool if a state did defects in value as a framework. Because I've been pushing CMS, like, because what we measure for, like, we measure 2,500 measures for CMS, and I chaired the prior Trump administration's executive order to revise it, and we gave a game plan for this, but the current measures don't fit a framework. So like with those 3 domains, as a clinician or an administrator, it makes sense, right? I could think about preventative care, chronic care, and acute care. Like whack-a-mole measures, like how do I manage to those? So great question.
Thank you, Elena. Board member questions? Guess I'll start since I'm off mute. These changes seem like such a drastic cultural change from how your hospital system was run. How did you go about achieving that cultural change? Because I think what we're trying to do in Vermont is similar to what you have achieved, which is what we all talk about: driving care out of the hospital, keeping people healthy, and managing to Medicare. But as you noted in your remarks, the historical practice is to grow revenue and protect margin. So how did you change that mindset of the whole organization?
Yeah, so great question. That Helen and Rose story was repeated many times, and it was powerful because what I challenged the board to say is, we were not founded to have a full hospital. Like, go read our charters. It's not in there. We were founded to meet the health needs of our communities. And making Helen's 15 readmissions invisible at your board meetings is irresponsible, right? Because we don't. I mean, we count every admission as if it's a good. Like, you know what I mean? Oh, look how full we are. Where the hospital's at 95% occupancy. Aren't we great? Well, yeah, okay, but if you look at medical admissions, 70% of them don't need to be there. So I had to balance that with saying, but we can't go bankrupt, as we're doing this. So we have 800,000 people on our ACO. About, at the time when I started, 58% of their care was in network. And when I say care in network, we have 2 measures. One measure, the numerator, is the dollars spent at university hospitals. The denominator is the total dollars spent in Ohio. and the other measure is visits, the same. And so what I committed to say is we won't go bankrupt, but we're going to improve access to our community of needed care by driving that network integrity. So our network integrity is up like 86% now. Every point is like $4 million of new revenue, so that we have grown our admissions, well, our surgical admissions and our cancer care, because we happen to have demand, like I'm sure your big hospitals are in that we closed 2 hospitals that were really low volume that needed to close. I mean, they were hard to do for our community, but and then what we said is, but that will also make up performance in our ACO. I told you in the beginning, our ACO was kind of was no contributor to our net income. Now it's 40% of our net income. So people are saying, okay, this is working. And for your culture change, which was, I think it's a separate, so that was like the CFO buy-in to say, how do I keep this balanced? And what, essentially the message was, again, in your scarcity or separation mindset, you think winning in fee for service and winning in value are at odds from each other. I don't believe that. I think in a mindset, they can coexist and you can thrive in both. But we do that by getting cost and waste out, keeping those medical admissions out of the hospital and filling them with people who need to be there, right? So it's not delusional. And I make sure I have the demand by growing network integrity. So it is a very intentional balancing act, and one can't get ahead of the other, or else, you're gonna go bankrupt, but you could navigate it. The internal culture change, I think, was probably more fascinating to watch and more risky. Is like, these are kind of radical concepts, for talking about a health system, and the clinicians totally resonated, because every clinician hates waste. I mean, they want their patients to get high value care, right? That's what people went into healthcare for. And they don't like charging people more or giving them services they don't need, but they didn't really have a mechanism to do this. But the way we grew was that Tuesday meeting I mentioned was probably the most catalytic thing to change culture, because we had our framework, but in all transparency, outside of me and maybe 2 other people, I don't know that anyone really got Believe, Belong, Build, because like we would sing it, but we would build management systems and they would implement them. But we would say, okay, primary care docs, we're going to improve our annual wellness to 80%, and we're going to be accountable for that. So, and then it snowballed where we would get a proof point and people were saying, wow, this actually isn't just, it feels good, but it works. And then we would get some more proof points. And so, like, for example, the slides that I share with you, I did for a UH meeting. I've done several times for UH meeting of like the 1,000 or 1,500, 12 top leaders in our system. And what I titled it is The Path to Proven Performance. And so we build credibility in this to say, hey, you may think this stuff is soft, but let me show you, what we can do. And I got pushback for some people in finance or UM, and like, yeah, Peter, this is stuff. That's not what you do. And I'm like, okay, so let's just look notes. Show me what you've moved the needle on in the next year, and let's see how it compares to how I move the needle, right? And maybe you got a better mousetrap. Love to learn about it and use it, but I suspect you're going to be hard pressed to show one damn thing you move the needle on, because that's just the way healthcare is. We haven't had good management, and then so it went from, okay, challenging. Now this OKR methodology is literally everywhere in the organization. So like we're working with our UM and our denials, like I showed you those measures. Well, those weren't under me, but we basically said, okay, how are we going to measure and do performance of what we're doing, and even looking at productivity of the physical therapy reports to me. We had 40% of our physical therapy appointments were missed, not because they're lazy, because they didn't have any insights into if the patient was available or not. And when I dug into it, what we found is when we put Epic in, Epic has a tool called the Brain that was only given to nurses, but it shows the patient's schedule and what they're doing. And so our therapist said, well, why didn't we get access to the Brain? I said, I have no idea, but you will tomorrow. And now our missing appointments are down to like, I don't know, 2%. And we have what we call level 1 patients, where patients who are going home that day, making sure they're seen within 2 hours of that appointment. And I mean, they're just stupid examples, but what we did is, if I were recommending this, it's going to need a champion at some hospital or at the system. Doesn't necessarily need to be the CEO. My CEO supports this very strongly, but they have to buy into this, especially the management system of, we're going to measure things that matter. We're going to transparently report that. And if you don't have a run chart, like, you probably need to do some more work because you're not sure what you're doing. Sorry, my computer went on freeze, and so I was looking at a blank screen. I don't know if that answers your the question, but it grew slowly, and as more and more people see the power of this, I mean, I'll share with you, and I say this with all humbling. I've been doing improvement work a whole long time, on some individual harms and safety things, on some all harms, and now for value more broadly in a whole lot of defects. I have never seen a management approach that is within a log order as powerful as this. I mean, it is, as I say, it's the path to proven performance. And I showed all those run charts because it's almost foolproof where it's deployed. But you build trust, you do the believe, belong, build parts of this. And, in so many ways, like, if you say, Peter, this is nothing new, I mean, you're right. Like, treating people with respect is in every wisdom tradition that exists for thousands of years. I mean, this isn't rocket science, right? I mean, it's in Christianity, Judaism, Muslim, but for some reason we've gotten away from it. And the same thing with good management. I mean, we haven't had good management. We've had, a system in healthcare where if we don't make our budgets, we ask for more margin. And I think we have to, there's a lot of opportunity to do this. And I say this fully acknowledging that, we're probably 30% of the journey of getting waste out. I mean, like, there's so many defects that we're still riddled with. Some will be technology driven. Some I'll give you one other example. To get labor costs down, really simple mindset change. In the past, most of what labor costs were like a hot potato. Is the nurse going to do this? Is the care manager going to do this? Like, there wasn't really work takeout. It was thinking. We said, okay, I don't care what role does this. Put that aside. We're going to look at tasks. And for every task that a patient gets, we're going to look at 4 levels of adding value. What could we just stop doing? So that was our policy work that I showed you, right? 2,600 policies. Just stop doing it. It's stupid. What could we automate with AI? What could we either have a lower cost staff do, or do with a remote person who's more productive? And then last, what stays sacred at the bedside? Meaning, this is the secret sauce that you as a nurse bring to patients. We need to guard that precious gift, but get rid of all, like, the other notes. So I'll give you an example. For nursing tasks, we did this exercise. I mentioned the policy thing that took about 30% of the time. We did this task analysis that we deployed a remote hospital room. We use this company, Vital Chat. I have no relationship with them, where we put a nurses remotely. They're from that unit. We've done 156 beds from 5 different hospitals where they do remote discharge and admission. They're like the safety lens. They monitor for falls, or we use AI for falls. That has been about a 15-to-1 ROI. It cost me about $750,000. I paid for it with that venture philanthropy gift, and now we're spreading it to 2 whole hospitals and about half of our big academic medical center. But what could be done by a task analysis? I'll give you an example. We looked at the care team of tomorrow. It says who could do these tasks. It doesn't need to be a nurse. And when we dissected the tasks, one of the tasks that we came up with was, patients' personal hygiene or bathing. And what we found is that there were some LPNs or MAs who took such pride in personal hygiene. Like, I mean, it touched their soul. Like you can see they cared deeply. And the way they cared for people was keeping them groomed or keeping their baths. So we created a role called personal hygiene expert. And their job just does personal hygiene. When we designed this, the way we did it was to say, think big about what roles and tasks you do, but the constraint is it has to be 20% overall labor cost. Now, in the first round, we got to like 10% overall labor cost, and we're whittling it down. But more importantly, it was so much more effective because people were joyful. It was doing the job that they want to do, but nobody had said, forget being constrained of, I'm a nurse, these are the things nurses could do. I'm, the patient care assistant, this is what I can do. It's just say everything's on the table, look at the tasks, and outside of, state regulations or federal regulations, could we be creative? And I share that, Owen, because I go back to the culture. If you don't have this culture of love, you can't break silos and work together like that because they don't trust, right? People would hunker down and say, no, this is what physical therapy does. This is what a care manager does. This is what an endocrinologist does. Get out of my space. And no doubt we had to overcome that. But when you come with this different mindset, it allows people to free up and say, hey, there's plenty of work to go around. Let's just all do it from working collaboratively.
I think, yeah, some of these are things that we as a state are literally currently working through and getting over, I think. Some of the things you touched on. Just one other question. Clinical productivity, you said you were benchmarked 40th to 60th percentile. This is something the state in Vermont, we see numbers quite a bit lower than that. And one of the concerns raised is that providers won't want to be pushed, that they want to do research or that they want, they came to Vermont for lifestyle. And I wanted to hear your reaction to that because it sounds like that was something that you.
Oh my God, yes,
on.
yes. So I would just say right now, across all of our physicians, our productivity is 78%. And we look at who's low, and they have improvement plans to get lower, or if they're going to stay in our organization. We supplement, and some of our physicians don't like that term. For example, I think our average subsidies for like urology and ENT are 280,000. I mean, and this is national benchmarks. We're not an outlier. Primary care is probably in the 200,000 or 180,000. And again, they bring in revenue from that, but those are precious resources. What I would say, if I would encourage you, is prior to kind of this approach that we are talking about, it was this scarcity fighting mindset. So administration would say you're low productivity and threaten people. The docs would say, no, I'm not, or this lifestyle. But the biggest issue, the data was horrible. So so when I say 75%, I mean that's for clinical FTE. So if you have grant funding, then, for 30% of your time, then you're a 0.7 clinical FTE. We also, though, Owen, also looked at, okay, of that 0.3 for grant for research, how much of it is funded? If it's not, like, it can't go on forever because someone's paying for that, right? So it cleaned up both sides. But once we had clean data of what your clinical responsibility is, and we agreed on standard ways of measuring productivity, we managed to that. The biggest part that of the change, so we had standard metrics. We and I won't bore you with the terms, but we can go through this if you want. We have a measure that every slot that a patient has, the goal is 100% booking, right? They don't all show up, but like when it's scheduled, those slots in this office should be scheduled, and then the visits are somewhere around in the 94-95% range. We use some AI algorithms because we know there's in our place around a 13% no-show rate, so we overbook around 13% to accommodate for that. The biggest change with the physicians was we were sloppy in our templates, and the physicians had their own templates, and and it's complicated, but they had rules like who could be allowed to schedule, or their office would schedule. And, I only saw people with these diseases, or I only saw them on these dates, or I like to not work on Fridays, which is like our productivity on Friday. I'm not sure. I'm curious what in your state it was like 15% because people don't want to work on Friday. And, that was another very clear. The productivity on Friday will be no different than the productivity of any other day of the week. And we worked a lot with our physicians to get it at that level. But it was, the mantra is waiting is suffering. Like patients waiting 3 weeks to get in. And then probably one of the other super important thing that we did was we created a type of visit that we called an ambulatory emergency. And because what I found was that, the patient experience and grievances, all roll up through me through this, my responsibility is I would get these letters that, my son's having a seizure and I was told it's 2 months for neurology, right? I mean, and if you're a parent, you could just sense that fear. It's horrific. Or my loved one has something that's like some acute thing that I don't need to go to the ED necessarily, but I need to be seen. But there's a disconnect to that urgency of the patient and the person's schedule, right? And I get it. And so we had our departments to say, tell us the conditions that are ambulatory emergencies or urgencies, and we agree that is those patients are suffering. They will be seen within 48 hours. And if you have to overbook, we'll just overbook them. We're not going to allow our members to suffer. And it was transformative, right? And that took care of so much of the problem because there's some things that it's okay to wait a month. But there's other things that it's completely unacceptable for patients. And I don't know if that's the best solution. It's how we solved it, but really simple. They defined what they were. Obviously, we got patient input to say what they were, but a lot of them are just kind of common sense. You ask patients or you ask a specialist, what are the things in your area that need to be seen pretty urgently? A final thing I would say on productivity is some of our hospital-based physicians' productivity is out of their control, and so we need to think of different ways. Some of that also was we had no mechanism to make sure our hospital people were billing for every patient they saw. We do now. So some people weren't, collecting the money that they could. And then finally, our pediatrics, and I suspect there's, even though we're a big geographic area, there's just not that volume of some of the ped specialists. And so it's hard to maintain, that. And we have collaborations with other pediatric academic systems in Ohio to share, because we ended up just being in a price war for getting cardiac surgeons or these ultra high specialists that there just wasn't the volume to support, 2 or 3 academic health systems, but we haven't regionalized that. And I suspect you have that in, maybe even worse in Vermont. And it's really expensive maintaining. The children of Vermont should have access to tertiary and quaternary pediatric or adult care. But you don't need 3 different places or a number of places that do it. And it may even be cross-state collaboration for some of those, because it's both very expensive to maintain that infrastructure with low utilization. And it's also not safe because you have very low volume places who don't get the expertise. I'll give you an example of another place we did this was OR scheduling. Our OR productivity was around 50%. And that's because people were controlling block rooms. But we had demand that we weren't measuring it in a standard ways. We agreed, we will measure it in a standard way that, essentially is this time used, not your specialty, who has a hold on it. Our OR utilization across 18 hospitals now is 82%. And to do that, we use the Fractal system. So we created a system perioperative value committee. Every hospital has a voice and they navigate it on their own. But we have a standard management system of saying, this is how we're measuring productivity. These are the expectations of how you're deploying the block. You can figure it out, but you will be managing to these goals.
This has been really helpful. There's a lot of ideas and concepts that I think we could leverage and implement here. So thank you very much for being so generous with your time. And we'll probably have additional questions. But thank you, Dr. Pronovost, for being so generous with us. We have a lot of work to do, and this is helpful. Other board members?
Hi, I have a quick question. So I was curious, you talked about how you were able to balance the value work with keeping people in network as a way to grow your demand. I'm wondering if you could talk a little bit about which strategies you think might be applicable for hospitals that are either not in a multi-hospital network or are geographically isolated or smaller, because that's most of our hospitals. We have 3 in one network and 2 that are in a Dartmouth network across the river. Right. So just trying to get a sense of like,
so good thing, right? And when I say that the network integrity, I should have been more clear. Those were the patients who are in our ACO. So when we use the term population health loosely, and my apologies for being sloppy in my language, we have 4 populations that we care for, and we have different roles, responsibility, and measures for each of them. The first is our employees. We're fully self-insured. We do a whole bunch of things to keep them healthy. Second is those we care for on fee-for-service, which is our mains one. Third is those we care for in our ACO, or those we insure, which is about 75% of the fee-for-service. And then the fourth is those we live with. So many don't have an MRN with us. They're in the community, and we do different things. But we stratify those 4 groups: those we employ, those we care for, those we insure, those we live with. The network integrity, I was referring to those we insure in an ACO, because we have full claims data on there, and we could do, and so anywhere you have an ACO, there's a lot of really simple things that ACOs can do, like scheduling appointments before they leave, feeding back to the docs the data. Are you keeping them in our health system? And if not, why? And so I think that for those who don't have that, I think the way to focus on this is getting the cost structure down so you have a positive margin on those you have, because there's still a lot of fat in those. And then as you deploy some of your quality things or your cost reduction, or you have capacity, working with your community docs to be a center of excellence for those things that they're doing. I know one thing I'll just leave with, because I think healthcare needs to solve our cost and quality problems, and what we've tried for 30 years or 20 years, or Tom, you could know better than I can't think of like a scalable success of like material cost takeout at like of per member per year. And so I think opening our minds to some new way of thinking is really essential, because the current way of scarcity, or the absence of love of separation, battling for a nickel, hasn't served anybody well. We're battling for it, but health systems are still going bankrupt. And and our patients are going bankrupt, and employers are, are struggling. So I would just, perhaps my plea to say, could you open your mind, perhaps your heart, to think of, is there an alternative way?
Thanks for your time.
Yep, thank you. Have a great day.
Did he go? Are we gone?
It's like a great mic drop.
Sorry,
I
was
was just
not
going to ask a
intending that.
question, but I guess we can't.
He might be back. We had a pre-meeting with him and this happened. It just suddenly stopped. I don't think that he meant that, but I might be wrong.
Oh, wait a second.
Yeah.
I think he meant to go. All right. We can take public comment, and for board members, we can certainly reach out to Dr. Pronovost, and if there's questions from the public that we want to forward along and get responses to, we can do that as well. So I'll start real quick with the healthcare advocate, and then I'll go to the raised hands, which I see a couple up.
So that's funny about the mic drop. I wanted to say what a great presentation that was, and that I appreciated the focus on patients and measurement. And I think, that the focus on measurement and the importance of it, and the importance of doing it over time and doing it starting at a specific time, it raises interesting questions about, like, is the measurement that's a hospital should be doing, that's clinical, different than measurement the regulator should be doing? And so kind of thinking about the levels of information and what's relevant at each of those. And I would say for regulators, there is a question of, like, well, how are you hospital measuring? What are you measuring? And why did you select those measurements? Do they make sense in terms of our larger goals? And the more and more I thought about it, I came to really like the concept of love, because I think there's, it speaks to, love includes having imagination. And I think we have a paucity of imagination. We just sit with what is and what has been, but we know for Vermonters, and really for everyone, it doesn't work. And I would say another part of love is self-criticality, right? Saying when you're wrong, like evaluating whether you are doing the right things. And that kind of brings me to something. I read a Burlington Free Press article this weekend, and it was talking about Blue Cross's current RBC position. It said what its RBC position was at the end of 24. And, I read that. I then went snowshoeing with my spouse, and about a mile into it, they said to me, "Are you thinking about work, Eric?" And I'm like, oh God, I am. And it's because whenever I'm thinking about work, I have this horrible thing where I mutter to myself and move my hands really rapidly. So she knew, which was quite amusing. And at this point where the RBC position of Blue Cross is tenuous, and I think I said this in rate review, that I was even concerned about it based on their 2023 results. I think it's also important to remember that we're also talking about the healthcare system as a whole. There is no doubt hospital prices play into that. There is no doubt in my mind that we don't have systems of measurement that are valuable for Vermonters across hospitals and payers. And how do we know that? Because the system doesn't work. But so this notion of self-criticality really made me think. So the quotes in the piece, if you haven't read it, were Brumstead blamed three things. He blamed hospital prices, and no doubt they play.
Sorry, Eric,
According-
I think you meant Freudian slip. You said Brumstead, but I think you meant Don George, I think.
I did. I can't keep the CEOs straight. I'm sorry, Chair Foster.
Dr. Brumstead is retired and enjoying his retirement.
Freudian slip. And he said pharmaceutical prices, and he also said the GMCB regulation. And look, I mean, the press pulls out quotes, perhaps it was out of context. I don't know everything that was said in the interview. But that really got me thinking as this presentation went on. And I think it's important, even at the point where we're thinking about what do we do to stabilize Blue Cross, and how is, you know, the hospital system, in particular UVM, because they account for such a huge portion of spend in the state act, we don't forget that Blue Cross isn't self-critical. What didn't get quoted, what Brumstead didn't say, what they didn't even say in rate review, that they had made any mistakes. They didn't talk about the losses in the administrative services line of business. They didn't talk about the losses over the last few years in the large group fully insured market that are due to multi-year rate guarantees. They didn't talk about how bad of a business decision their investment in the MA plan was, let alone what people think about Medicare Advantage. And if you should even be in that market, it was objectively a bad business decision. You know what they also didn't talk about? How they cannibalize the healthiest people from their insured, fully insured market with the Blue Edge product. No discussion of that. So as we think about dealing with the current crisis, I want us to think about that we both need to think about hospital prices, but also what is our insurers doing? And why do we need to do this? Because the current system doesn't work for Vermonters. And when hospitals and insurers point fingers at each other, I guarantee you, the people who lose year after year after year are Vermonters, but we pay for them. Thank you.
Thank you, Mr. Schulteis. Dr. Gulper, nice to see you. Thank you for being here. I see your hand raised.
Yes, but actually, Jude.
Oh, I'm sorry, Ms. Pigley, I'm sorry. You're in my top corner here. Yeah.
Yeah, Judy.
Hey, Judy.
Thank you. Hello, everyone. So thank you for bringing forward Dr. Pronovost. And I actually just want to make a few comments of optimism. So when I was writing down what he was saying about 2021, positive margin, 2022 loss, 2023 loss, but a lower loss, I felt like I was right there in that journey with him based upon my entry into the state of Vermont. So and looking at the struggles that they had in their market was very similar to what was happening nationally and what happened here in terms of the need to rely upon costly augmented workforce through travelers, the inflationary components that were increasing faster than, really you could even keep track of. But where I got encouraged was, so it wasn't just a let's all get down and say yes for us. And during that time, it was really encouraging to see what they had done and how it aligns with UVMMC. He talked about using OKRs and Viva goals. And I was able to go check, we're in alignment there. We've started doing that as well to try to spread that concept of we're all responsible for the cost of care. And when he's talking about investments in pharmacists in primary care, I think of it two ways. We made the decision to do that as well to ensure that patients get the care they need when and where they need it, because for patients, it's not just about the cost to them financially, it's about the cost of their health. if it's delayed, they have to wait. If they can't get it on a, a particular time frame. So making that investment will initially add cost of care, but will eventually bring down cost of care. When he was talking about the scheduling templates and things, that's also a recent move that we've made here and that I had been used to seeing in my background in health systems I'd worked with before. So I'm glad to see the medical center and all of our providers have moved in that direction. Where I also agree with him is task flexibility, and we're not there yet. We have staffing shortages in certain critical areas that in our current environment, we are not nimble enough with being able to have task flexibility. Now try to say that 3 times in a row. But I see, we have shortage in phlebotomy. And so we need, sometimes that impacts our patients' wait times. And so I would love to talk more with him and have availability on how did they manage to work together on being able to be flexible around the tasks that need to get performed and less about who performs them. So I thought that was really good. And then my last piece that I was hoping he would stay on was to find out where they ended up with their $20K on their inpatient cost that was higher than their payment. And when they reduced their Medicare cost by 30%, where did that put them in? So certainly open to Tom a reach out on discussing more about that, because there's a lot that's in parallel with what I've been seeing here at the medical center since I've been here. And the last piece I will say is, I think that all of us on the screen, all of the network and all of the Vermonters are really starting to come together to look at what is the true cost of care? How do we deliver it? How do we deliver it at a cost-effective way? But what does the pathway look like on how we invest so we can get to that lower cost of care? So again, thank you for bringing that on and appreciate the information. And would certainly love to have some follow-up information from him and very familiar with the entities in which he represents.
That's great. Thank you. Yeah. And as we think about hospitals and what they're doing out in Cleveland, comparing our outcomes and results, not just the process of I'm doing this, we're doing this, they're doing that, but are we actually achieving the same level of expense growth and the same level of commercial cost restriction? I think really I took that away from the presentation, that's really someplace we have to start, and what are we measuring? Okay, Dr. Goldberg?
I'm sorry, before Dr. Goldberg, this is Tom and Judy. I'd be happy to pass those questions along to Peter. I know that he'd be interested and willing to talk further with you. So if you, I tried to write them. I don't know that I got them quite as well as you said them. So if you'd send those to us, I'm happy to pass them along. Sorry for the interruption.
Thank you. Are you hearing me, Chairman Foster?
Yes.
So I'm new to Vermont. I've been here a couple of years. I work part-time at UVM, and I was 25 years at Vanderbilt, and I had a major administrative and medical role there. And I've been under the influence of Quint Studer, Studer, for over 20 some years. And I see Mr. Walsh raising his hand or nodding, so you know Quint. My major suggestion has to do with the theme of love. And I would like to see in some way an improvement in the love status between the Green Mountain Care Board and the UVM network leadership. I go to their meetings and I hear some things, and just you can kind of tell with the comments that the relationship is not as good as it might be. And I'm not putting any blame. This is just an observation. And just that presentation today was incredible. I have a whole page of notes, just like many of you do. But I would love to see an improvement in. I would like to see greater, I guess, respect, and that has to do with the theme of love. And I'll leave it at that.
Thank you for your comment. I'd push back a little in that I think sometimes relationships a lot better than what people think from the outside. I actually think that we have a pretty good working relationship and frankly improving dramatically as we go and work through things. But certainly a regulator and regulated entity relationship and structure always has its challenges, and we all do need to make sure we're acting professionally and working as well as we can. Walter?
Hey, Owen, how's it going?
Really well. How are you?
Well, no worse yet. One of the things that struck me as a frontline worker and as a patient and as an activist and as a general hippie with a mustache is that we need presentations like this. And Eric said it, talk about the love. In my view, this should be obvious. And I've sat through so many of these, like managers come up to give us these presentations as they're berating us for not producing enough because they don't want to pay us anything. And they want us to work long hours with no pay. And we had it when Eric said it, but when he mistook John Brumstead for Don George, it should be remembered that both of them are having very nice retirements courtesy of us, the ratepayer, the fee payer, and that as you saw in that Time magazine article, many of us have no retirement at all. We are not allowed the same rights as them because we ourselves seem to be beneath them. And I did mention that I was with the Green Mountain Care Board in the article, and for reasons I don't know, they didn't print it, but in any case, I did. Another thing that gets me is that we always have to listen to experts like this gentleman here. It's like, and I've seen it all through. You know, I spent 45 years in the hospitality business, and I've been lectured by people who have PhDs telling me how to be hospitable just because they have PhDs and I don't. So that's one of the observations I had with the presentation. I mean, otherwise I agree with a lot of it, and Eric Schultz has summed it up, so I won't reiterate it, but those are the things that struck me about it. You know, if you want to talk about love, that's a great thing, but it shouldn't be love in one direction. You know, Brumstead made millions off of us. And he gets a nice retirement, and me and those other three people in the article have to keep working. So when you think about that, we should think about that too.
Thank you, Walter.
And that article came out in print too. It's in the March 10th issue with, what's it, women leaders on the front. Women leadership, which is much better than the alternative of Musk, Trump, or Vance on the cover.
Well, thank you for your comment, Walter, and for your work with Time Magazine on that piece. It went around the board, and we all read it. So nice work.
Kate was there when it happened. Kate O'Neill, or she was there, so she was the one who But I spent months working with that reporter and working with Time. They followed me all around. They came to my apartment. I do have some hilarious stories about it.
Well, if Miss O'Neill can come up with a plan to wrangle pharmaceutical prices, she'll be next in that women leader cover for Time magazine. So,
Well, you should put her in there now.
well, she deserves it. She's wonderful.
Yeah.
Mike?
Thanks. I think the comment I would have wanted to make to Dr. Pronovost, or question I would have wanted to ask, and Tom, I don't know, maybe this can be forwarded on. It's sort of a version of the same question you asked Owen about culture change, but about an organization that's not willing to step into it. You know, like what would Dr. Pronovost say if he was, you know, talking about the system change that he's been working to achieve, and a hospital said, "We're different. We're not like you. We can't do what you did because, I don't know, we do such a good job of providing community care at a loss, or we're part of a different state that has different dynamics, or a whole host of reasons why the kinds of change that he talked about didn't apply to their hospital." I'd be curious to hear whether he would say, "Not so fast, I think this applies everywhere," or whether he would say, "No, this really only works." You know, I'd be curious what kind of response he would give.
Third question.
I'd be happy to pass that along, Mike. And he should respond himself. That is a question when we had a pre-meeting on Monday. A couple from the board staff were there along with myself. That is a question that we started on and wanted, hoped that he would address. And he talked very eloquently during that meeting about how the work to overcome some of those challenges. All of the pushback that you mentioned, the uniqueness, why this can't work. And he was very deferential about, he's got a certain style, a certain high energy and love. And is it just somebody like him that can do it? And he was very much like, no, I learned from people who have done this. And so if I can learn, others can learn it, and you can do it. It's not easy. He talked of bruises, not physical ones, but bruises that he's had from the work, and some tough choices. And when he's talking about RIFs, for example, those are reductions in force, and that those were very, very painful for him, and making choices about who was willing to move forward and who wasn't. So, but I'll share your name, your email, if it's all right, and pass the question directly to him. My guess is he might reach out directly to you.
Thank you.
Okay, any other public comment? Mr. Del Treco?
Sure. Hey, Chair Foster and members of the board. I thought today's presentation was interesting and a demonstration of what can be done as we continue to work together. One of the things that from our conversation is we're all in on working on developing predictable and consistent measures with over time, and to see where we're going and how our changes impact these numbers. So just wanted to reiterate, we are all in on measuring and understanding how the changes we put in place impact our business, not only outcomes in our hospitals, but downward pressures on premiums and improvement in our insurance industry. So just wanted to reinforce that in the moment. Thank you.
Thank you, Mr. Del Treco. Ms. Snell?
Yes, I just wanted to thank you for this presentation. I will freely admit when he started talking about love, I was like, oh dear Lord, what is going to happen? But at the end, he won me over and gave me some great ideas to try to help our hospital move forward as well. And I guess, like Mike, my question would have been a little bit about the culture, because we've always been told, like, assume good intentions, but after a while, when those intentions don't pan out, there's a loss of trust. And how did they rebuild that with their staff from that point of, like, not listening to being active listening to what's happening?
Thank you, Deb. If it's all right, I'll pass your email along with that question.
That'd be great.
And the first time I talked with Dr. Pronovost on the phone and he started explaining more of his theory and approach, I had the same reaction. But he won me over as well. It's inspirational.
Mm-hmm.
Great. Any other public comment? Any new or old business for the board? Member Walsh, thank you very much for your work on this. We appreciate you taking the leadership on putting this all together. It was great to hear from Dr. Pronovost. And I will move that we adjourn.
Second.
All in favor, say aye.
Aye.
Aye. We are adjourned. Everyone have a nice day filled with much love. Thank you.